Okay, I'm going to open the floor for questions now, but one of the things I'd like to just kick off with is the following thought. In my practice for coronary surgery just now, almost 20% of my patients are over 80 years of age, and a common scenario for that patient being referred for surgery is a very tight, calcified distal left main proximal LAD disease. In all of these patients, I do a median sternotomy, take 2 skeletonized mammaries, I put them on the 2 best left-sided vessels, so no bypass, don't touch the aorta. And the risk of a patient in that situation who would otherwise be at high risk for stroke is very, very low indeed. Now, I can do that operation very comfortably. And recently I did one from one of my colleagues in Oxford who didn't like the concept. He thought the patient had a porcelain aorta. So we did the patient as I've just described. And that, I think, is a quantum leap forward in these truly high-risk patients. The problem is, if you say, well, I will reserve off-pump surgery for my high-risk patients, I always think this is crazy, because the last time to change your technique is when you've got a high-risk patient. And this shows one of the, I think, things about off-pump surgery is that if you do it all the time, I think the coronary trial and the CABG trial have actually been a bit underplayed by opponents of off-pump surgery. Because for the last 5 years, the opponents of off-pump surgery have, with the Ruby trial and other trials, have said off-pump surgery is dangerous, it's less safe, you don't get such good results. And coronary and CABG show that is absolutely not the case. It shows that if off-pump surgery is done by people who are experienced in doing it, they can produce results equivalent to the conventional operation. But they also have, by doing it regularly in their armamentarium, the situation that when the really truly high-risk patient with that very diseased aorta comes along, they can deal with this quite easily and they're not out their comfort zone. So those are just my general thoughts. And now we've got Mohammed Imrani, a highly experienced off-pump surgeon.
Putting together what you just said now and what Manuel told us and Professor Pepper, don't you think that off-pump surgery should be acknowledged as a subspecialty? And we should at last consider a proper training for our trainees and indeed the junior consultants?
Yeah, this is a great question. So I was very privileged at the STS to sit with the STS leadership to have a specific roundtable discussion on the future of coronary surgery. And there were 4 of the very prominent North American surgeons, and their view is exactly what you've just said, Mohammed, that there should be a recognition of coronary surgery as a subspecialty within cardiac surgery, in that it is still 60% of all our operations. It's very largely ignored. I mean, you come to these conferences, you can learn everything about TAVI, AF ablation, transplantation, and yet there are very few courses on actually how to do coronary surgery. So I think there is going to be a move in that direction. At least you train certain units to have surgeons who do off-pump surgery based on composite arterial grafts who will really push this no-touch aortic technique. Please.
My name is Valentin Kolkov. I can actually, from practical point of view, say, because I finished my training in Poland, and I came from off-pump center in general, where 95% of surgeries were done off-pump. And coming to Irish practice and everything, everybody's scared of that. And I truly believe that it's completely different when the 50-year-old surgeon start to learn how to do, or just to go off pump just to see for a week or something, and start doing that. And to the trainee who assisted at least 300-400 cases a year for the last 5-6 years, and you can say he's trained, and I can obviously see, I know people from Poland, there are some surgeons for the last 10 years, he have maybe 1 or 2 conversions, so it's completely different approach. I think there was one study in Canada as well, that all the surgeons who are trained on pump, it's not like you underwent the whole training and suddenly you...
Okay, I think you've made the point. Let me see what our colleague Simon Kendall says.
I think you make very good points that it is a different technique to on pump. and that the younger you are, the more amenable you are to the new techniques. And is anyone who here thinks that off-pump surgery is easier than on-pump surgery? Okay, it's just two. And who thinks that off-pump is technically more challenging than on-pump? And I think that, for me, that is just a straw poll that answers your question, that I think as surgeons and people involved in surgery, we acknowledge that it's technically more challenging and therefore you need specialised training.
I think I can remember 10 years ago at the STS again, I was sitting on a panel when we were asked by the audience in an open discussion, how many cases did you need to have done off pump before you were proficient? And I had 4 or 5 people sitting on my right-hand side, and they were saying numbers like 20, 40, 50, 55. It came to me, I said at least 200, and people gasped. But I think the problem was we sold off-pump surgery in its early days as being very easy, anyone could do it. And so we created a rod for our own back.
One more thing I would like to say. As an off-pump surgeon, I think it is difficult to train in off-pump surgery. It's easier to train in on-pump surgery. There's a kind of a comfort zone when you are doing on-pump surgery and you can let the trainee do the anastomosis. It's very, very difficult, or more difficult in off-pump surgery.
I think definitely, although I'm an off-pump surgeon, I must acknowledge that off-pump has been oversold also to the beginning, and all these hype and hopes turn out not to be true, as you said, for neurocognitive things, etc. And that we are left with the benefit, no doubt. I think everyone would agree here that in truly high-risk patients, there is definitely a benefit for those patients. The true question is, how much are we willing to invest, or a young surgeon is willing to invest in learning a technique that is difficult and needs regular practice to decrease a risk in patients, although they are becoming more and more frequent, as you said, in your practices nowadays, the majority of your patients. And so that's the big issue. Because on the other hand, there have been improvements in on-pump. I agree with my opponent. Yeah. And you can do on-pump beating heart without clamping the aorta, with echo-guided cannulation, with minimally circuits, with no blood-air contact, with the MEC or the minimally invasive. So there has been improvements also in the on-pump, I must recognize.
Yeah. When Michael Mack was president of the STS, he said in his presidential lecture, "What's the difference between the cardiologist and the cardiac surgeon?" He said the cardiologist has used technology and innovation to make his job easier. Cardiac surgery has used technology and innovation to make her job more difficult. Off-pump surgery, small incisions, arterial grafts, robotics. And this is very true.
There's a question at the...
I think what you said is very true. How much are you prepared to invest? How much is a young surgeon is prepared to invest? Should he invest? I think if we think that the population we will operate is becoming more and more difficult, then the logical answer is it should. I think one thing we agree upon today, I personally think I do off-pump regularly for virtually all my patients, and I genuinely believe that for low-risk patients, it makes no difference whether you go on-pump or off-pump, but I strongly believe in high-risk patients, it does. If that is the case, and I think we all believe, then the logical answer is we should invest in young people, should be trained.
Let me ask the audience then, just before the next question, how many of the audience believe that off-pump surgery does have potential advantages in the truly high-risk patients? Probably about 2/3 of the audience.
Yeah. Possibly more. Sorry.
I mean, we've been through probably about a decade since this off-pump surgery controversy started. A decade of trainees have gone through United Kingdom training program. And we are still talking about creating fellowships and the programs. Now the question comes is to do with the technique. We agreed it's a difficult technique. And how often surgeons who have been trained even 50 cases or 100 cases, when they get a consultant job, that first year or 2 years, they go on doing off-pump surgery or on-pump surgery. Now, is it a time when, for a decade, the procedures have not increased? It remains static around 15 to 18% level. I mean, there is a question, big question about this. So whether you invest in one trainee or 2 trainees to have that special fellowship, and that will make a significant contribution to UK population, I'm not sure. But I'm just putting this question for further debate.
Okay, thank you.
David, I think I'll respond to Sai's comments. I think it's very important to understand that peer-to-peer training is disappearing in the United Kingdom. If you are trained in a center where off-pump surgery is performed as a routine, the trainee will end up performing procedures off-pump and will, when appointed to a unit where off-pump is not the flavor, would try and introduce it. There are examples out there where people have been appointed in centers and they've taken up off-pump and they have established off-pump programs. I think the key thing to understand here is, I think what we are missing here is, I mean, it's the same old debate, and I agree. I mean, we see the same data shown. It's a debate that has been going on for 20 years, and I think the time now has come, as Mohammed said, to acknowledge off-pump, like some of the other minimally invasive techniques, as the techniques for the future. I mean, if we are not going to train our trainees in this day and age to perform off-pump, we will be giving up majority of our practice to cardiologists, because the future of revasc is Lima to LAD. Lima to LAD is the only graft that has proven benefit compared to stenting. And the future for revasc is an octogenarian requiring a Lima to LAD and stents in a hybrid theater. If you're not performing off-pump Lima to LAD through a minimally invasive incision, you are giving up a major chunk of your practice as a revascularization surgeon. And I think that is something that we need to acknowledge, and we need to establish training programs. And I'm not suggesting that you need to establish a training program at every hospital, but this is something that has to be acknowledged as a subspecialty with 4 or 5 centers in the UK, and people should go there, get trained, and this should be accepted by the Society of Cardiothoracic Surgeons.
I mean, the only comment I would make is, I agree with you to some extent and disagree with other parts. The most important thing, and where we offer most value for money for our patients, and we'll talk about it in the next session, is making sure most patients leave the operating room with 2 internal mammary arteries, and that's far more important for most patients than whether you've done them on or off pump.
I just want to emphasize that point, that if you're going to create a subspecialty of pump surgery, which sounds very sensible, this is the opportunity to try and improve arterial revascularization, which is woefully low.
It is.
Not just in this country, but
sure.
across North America.
There is someone waiting at the back to ask a question. I'm sorry, I can't see who it is.
Sorry, could you take the microphone and slide?
Just wanted to point out the training issue. We had Mr. Omrani who came to us in Egypt as a center in Maadi Hospital. And there were, I think, 3 to 4 surgeons, as he remembered, in a different age group. And he trained both 3 of us. And I think that we took off pump at a different level of age, and we started the program, and it tickled up. And I think the training issue at any age level, if you're getting it properly, is not an obstacle, really.
Thank you.
Thank you. Julian Gear?
David, I think the modern version of John Pepper's 4th century aphorism, of course, is that we cite the best examples in the literature when it confirms our bias, and we hide behind a lack of statistical significance when it happens not to confirm our prejudice. And I think I'd be interested to know, of all the various straw polls that we've had, how many of the off-pump enthusiasts use a rigorous no-touch technique or as minimal touch technique for all of their off-pump surgery, and how many of the on-pump enthusiasts are doing the operation with, as you know from Brian Buck, your association with Brian Buxton, single cross-clamp technique with all of the anastomoses being performed under a single period of cardiac ischemia. Because I think that's the obvious, because we end up always citing a paper that was published 10 years ago.
Yeah.
The next iteration in the evolution of that is the trial that compares a really rigorous no-touch. Because as everyone has said, the great advantage is the lack of neurological injury in patients done off pump. But you lose that if you clamp and unclamp the aorta 4 times during the operation.
Your point's well made. Yes.
Other questions?
David,
Jatin,
The question you didn't ask is how many of the audience actually who have been doing off-pump surgery have gone off it. Gone off it in the sense that we were concerned about the less than optimal grafting, whether it was the quality or the numbers of grafts concerned. Now, I've been doing off-pump surgery since the early 1990s, before octopuses and things came along. you could go back to the 70s, Julian. Yeah, but since the advent of octopus and stabilization devices, certainly it's become much easier with shunts to do off-pump surgery. I do still do off-pump surgery and take my registrars through it, but it's better if you just do the lima, as you say, in the front of the heart off-pump, and that allows you to train these younger ones to come through. But if you try to attack the back of the heart for the circumflex with a beating heart, quite often the problem I have is a concern about the output, cardiac output throughout this procedure, which does affect the renal function, although your data may not show that.
Can we just try and answer that for Jatin Desai? Is there anyone in the audience who's given up doing off-pump surgery as a result of data in the literature? Has anyone stopped? 2, 3. Sai, would you like to say why you stopped?
I mean, not because of the data, recent data. It's predominantly about 8 years ago, just solely for the training purposes, for trainees. And as you go through the learning curve of the trainees, and they have to experience the problem with off-pump surgery, which, as you know, David, the first 100 cases of off-pump surgery are always difficult. So if you're then subjecting a trainee to do those first case, second case, 10th case, 15th case, you do have some problems, and you have to go through the mortalities, the graft patencies. The cardiologist not necessarily will forgive you if the trainee has died or something that happened. So
David Jenkins?
I think we're doing the operation to revascularize the heart, and that's the key thing we're doing. And as some of the results came out, including John Pepper's randomized trial, I had increasing doubts that the revascularization was as good as the first example. And that's the reason we're doing the operation. So I think the trade-off isn't great enough in terms of reduced morbidity.
But David, I would say, however, if you look at the two most definitive pieces of evidence we have, the two really large randomized trials, they show that off-pump surgery is not inferior. So the Ruby... No, John... Yeah, well, I mean, but... Yeah, but hang on a sec, that's not actually quite true, because for the last 5 years, the literature has been full of people saying off-pump surgery is substantially inferior. That was the story. That was what we were being told. And what I'm saying is GOP-CAB and coronary show that that is not the case in people who are appropriately trained to do the operation.
We're all reasonably intelligent people around the world doing cardiac surgery. Why are fewer than 50% of people around the Western world doing off-pump?
Okay, so let me ask you. Okay, yeah. Well, let me ask you this, David. Why do 5% of patients in the UK get 2 mammary arteries during a CABG operation? You explain that to me.
Adrian.
I love being surrounded by really clever people who'll tell me about 4th century stuff. I'm not that clever, and I just look at it simply like this. Why, oh why, after 25 years, are still 15% of operations being done off pump? I mean, you know, am I an idiot? I mean, don't answer that. My SMP's here. But I mean, if something worked so well, even for a subset which was going to become the way of the future, why isn't everybody doing it? We all went to using mammaries in the mid-80s. Why did we all do that? Why still do only 15% of us do it?
Can I answer this question? I think it's a very interesting view that you have, Adrian. I think the key thing to understand is that 15 years ago, we were not operating on octogenarian. You were operating on a 45, 50 years old who could be done on pump. 20 years down the line, I don't know how much of your practice is octogenarians, but you end up getting at least 15% of your practicing population as octogenarian, who do not necessarily have to be subjected to a cardiopulmonary bypass for an operation which you did an off-pump. So I think let's not have this view that 50 years ago something was not valid and it is valid now, or vice versa. I think the important thing to understand here is it's a mindset. You either agree to perform it or you don't. And I think you are pretty much, if your results are good and you can prove it to your cardiologist, by all means, go ahead and do it on pump. If your cardiologist is happy with your off-pump results, you should just carry on practicing.
Thank you. I'd like to come in here and then ask Philippe Cole for his view as well after I've spoken. But part of this, I think, is about technical ability. And we all like to pretend that we're as good as each other. But mini-mitral is an example where I think it tests your ability and the team's ability. And if you've got a good team and you've got a good ability, then you get good results in mini-mitral. And for some of us, it's just that little bit too much. We find our level and we're more comfortable with the open technique. And I think some of that is to do with off-pump surgery as well, that we're comfortable with on-pump, it suits our abilities. And I admire the off-pump surgeons because I think they're technically more gifted than I am, certainly. And I think that there's part of that as well in terms of why it hasn't been more widely adapted. Philippe, you're very quiet there, so I wonder.
Well, yeah, I'm listening. I'm supposed actually to wrap that up on Wednesday morning, also to give a lecture on the tour. I think the first thing is that David, Jan Wilson, and I were lucky to choose this topic for discussion today because apparently it triggers a lot of interest. To come back to the guidelines, I think, or to place the discussion in perspective with the guidelines, I think, as we all know, it's not possible to highly recommend the use of off-pump because we don't have the evidence. I mean, it's not a class 3. It's not recommended, obviously, but it's not a class 1 either. It's like between a 2A and a 2BB, something like that for a particular subgroup of patients. If you look at the evidence, there is no trial where you could, on which you could base the very strong recommendation to say, well, off-pump surgery is recommended, 1A as opposed to on-pump. The evidence is more in favor of no touch of the aorta, as David said. I think that's where it's quite important. Where I agree also is that you obviously don't want to do that in 10 or 15% of your practice and doing it on the worst case scenario. That's where you're going to end up into problem. And also, what I think, having heard all the opinion, why don't we have only 15%? Well, I think the reason maybe it's more difficult. It's more difficult that, technically more challenging to be trained, to train, or to do it. And at the same time, it has not be really proven that it's a superior technique. If you look at everything. As opposed to, for example, mitral valve repair, it's obviously usually more complicated, especially when you go to the anterior mitral valve, to repair it as just to replace it, but you know that you get better results. I think that's the association of the two.
Thank you. We'll take one final question from this lady, because I don't think we've had a question from any ladies in the audience. So this will be the final one, and then Simon's going to wrap up.
Hi. It's not a question. It's just I could not suppress my desire to reassure all you consultants here. I'm a trainee from Bristol, where most surgeons are off-pump surgeon. So when I started operating, I had a choice of either learning it off-pump or not learning to do coronary artery surgery at all. I had done 16 cases on pump, and then I took up off-pump surgery. And I've now done over 100 cases of pump coronary artery surgery. What I'm trying to bring forth is, yes, it probably is a technically difficult procedure compared to on-pump, but when you are at my stage of training, and that's the option I have, we will learn. So I just wanted to reassure the consultants on the issue of training that if that is the way the times have changed, then yes, we trainees will learn as we are doing it in Bristol.
Thank you for that comment.
Thank you. My job is to do the take-home messages, and I think the take-home messages have largely been spelt out. I think a lot of us used Trasolol in the past, and it's only because there was a multi-center trial that it did show statistical difference, and a lot of us, myself included, have gone through the pain of operating without Trasolol. It's certainly exposed my lack of hemostasis at the end of operations, and I've had to retrain how to close patients in a dry technique. But interestingly, that over the 1,100 cases per year that we do in our unit, and the Euroscore has been getting higher, our mortality has been going down. And you sort of think that the pain of the reopenings and the excess transfusions and the relearning actually has been worth it. And just maybe that if, for the on-pumpers, single clamp technique was a drug, or if off-pump was a drug, that it would be mandatory that we do it that way for the marginal gains that are seen at the edges. So I think my take-home message to you all is, just imagine that you have to go through this massive operation as a patient, and just think what you'd really like your surgeon to do for you if that was the case. So thank you very much indeed. Thank you.